Okay, right. So welcome to the June meeting of the ICP. I just wonder how many actually people log into YouTube. It'd be interesting to know whether anybody finds it interesting. So perhaps get those figures. So the first item is apologies.
We've got apologies from Avia Batia, Chris Clayton, Michelle Arrowsmith is covering, Carol Camus, Mary Dooley, Chris Bridlington, Natalie Hoy, I think Alison Noble is covering, William Legg, and Stephen Posey and Gino Di Stefano, Mark Palber, Aaron Chidambaram is covering, Simon Stevens, James Moore, Helen Henderson, and Councillor Patton.
Take a deep breath after that. I think if everybody was here, we might need a bigger chamber. We'll probably have a couple of faces, but rather than go down and do introductions, it takes a while. If when you speak or you want to speak, if you just say who you are, then that will help the ones that are new. No late items come by the chair. Any declarations of interest? No declarations of interest, thank you. So then we've got the unconfirmed minutes of the ICP meeting on the 17th. It's really more or less for just for accuracy, because I think all the reports were for noting, so no real matters arising. So page 1, 2, 3, 4, 5, 6. I'm not sure whether I've even gone on to... That's it. I won't go through more page unless there's anybody wants to raise anything. No. So we accept those as true record. Thank you. So we'll get on to the first substantive item, which is progress evaluation of the VCSE Memorandum of Understanding. So over to you, Wayne. Thank you.
Yep, thanks very much. Can you hear me okay? Yep, good. Good afternoon, everybody. My name's Wyn Garnett. I'm the programme lead for engaging the voluntary community and social enterprise sector in the integrated care system. I've got a short presentation to take you through. You've had quite a lot of papers sent out previously, the full report, the evaluation process that's been used, and the original Memorandum of Understanding. So I don't intend to go through that in all of its detail. What I am going to do is to give you a little bit of quick context to the review, the process that was followed, the findings, and looking forward, some thoughts on looking forward. Just before I start on the presentation, I just wanted to thank some colleagues for the work that's been done. So this evaluation was done with a lot of input from Richard Morell from the ICB, from the PLACE team. So thanks to Richard for all that help, and to other colleagues. And a particular thanks to Kate Brown, who sort of was very involved in the MOU development last year, and has been a particular champion to the VCSE sector over the last few years. I know he's leaving us, so particular thanks to Kate. Thank you, Kate. So if you'd like to move on to the next slide. Okay, so in terms of background, most of you will be familiar with this, but I think it's just worth refreshing people's understanding of this. The need for a Memorandum of Understanding was something that was set out by NHS England, who felt there was a need for something that underpinned the voluntary and community sector's role as a key strategic partner. And it talked about the partner's key role in playing a contribution to shaping, improving and delivering services and developing and implementing plans to tackle the wider determinants of health. So within the national guidance, there was very much a sense that the VCSE sector was a core strategic partner, but there needed to be something that captured what that looked like. Now, in Derby and Derbyshire, we have a very, very thriving and active VCSE sector. So the last survey that was done some years ago suggested something like 9,000 VCSE organisations across the city and the county. Most of those, 70% of those, have no paid staff at all. But in terms of paid staff, it's a sector that employs around 10,000 full-time equivalent staff and 6,000 full-time equivalent volunteers. So we're talking about a sector here that's significant in size and has a significant contribution to make. Last year, the Memorandum of Understanding was developed after extensive discussions across the partnership structures in the integrated care system and within the VCSE sector itself. And it's probably fair to say that the discussions were as useful as what came out of it, because it got people talking about what the VCSE sector was, what it brought, how it worked together. So that was developed last year and adopted by the ICB and the Integrated Care Partnership at the Moving Forward Together event in June 2024. So it's been in action for around 12 months now. The MOU itself has two or three aspects to it. So it sets out a vision for the VCSE sector in Derby and Derbyshire. So it talks about the system wanting to see a thriving, diverse and sustainable VCSE sector that contributes as an equal partner to improve the health and well-being of people in Derbyshire. So that's kind of a touchstone when we think what progress we're making in terms of engaging it as a sector. And certainly over the last 12 months, it's been seen as key in that shift towards prevention and tackling health inequalities. The MOU also includes some detail around the kinds of behaviours and cultures necessary to generate trust and effective partnership working, and it includes several priority areas for action. So that was the original MOU. Next slide, please. And in terms of the evaluation, I think when we adopted it last year, there was a sense that there's no point in adopting something and putting it in a filing cabinet for 12 months or not looking at it again. We needed to come back and see what progress we were making. So there was a commitment to coming back to this after 12 months. So over the last few months, we've been undertaking a consultation exercise. It's used a tool that consists of 7 key questions that were drawn from the original Memorandum of Understanding content, plus some much more detailed question sets for those that were particularly enthusiastic and wanted to drill down into areas like data sharing. The report that you've had circulated draws on all those responses, discussions in the system, and also progress that's been made in particular areas of work. And I think it acknowledges that this has been a particularly difficult 12 months. It's been a challenging 12 months. The budget deficits that partners have faced, the proposed funding cuts, pressures on services, they've all made discussions quite difficult, and they've reduced the space and capacity to do some of the things that we'd have liked to do. So the report recognises that this hasn't been the easiest of 12 months to progress this kind of work. The response in terms of the evaluation was really positive. We had discussions across the system, but particularly in, I think it was nearly all of the local place alliances responded individually, but also discussions at the Integrated Place Executive and the City and County Place Partnerships, and also from individuals and individual statutory organisations. What was quite revealing, I think, in terms of some of the feedback we had, was that organisations found it quite difficult to respond as an organisation because people's experiences of working with the voluntary sector often was very different, even within the same organisation and sometimes within the same department. So I think that was revealing in itself because it suggests that there isn't necessarily a systemic approach to working with the sector. It's quite based on relationships. And some of the issues that were raised are not just VCSE sector issues, I don't think. They're issues that have got a wider resonance to the system and how it works. So next slide, please. This one we can just rush through quickly, but just to give you an idea of the 7 question areas that we used looking at this. So we were looking at the extent to which the sector was involved at the outset in initiatives. It looked at data sharing, representation, how local place alliances worked, investment, procurement and commissioning, workforce and cultures of partnership. So those were the 7 areas that we explored in the evaluation work. Thank you. So perhaps to get to the meat of the discussion, just a couple of slides on what came out of the review. Firstly, the progress that's been made. So there has been some significant progress made, I think, in terms of the VCSE sector partnership with others. Firstly, a real sense that there's a much greater awareness and recognition of what the VCSE sector can bring now in terms of health and social care, and particularly around prevention and tackling determinants of ill health. There was a lot of very positive responses around partnership working at local place alliance level and how embedded voluntary organisations were within local places. The VCSE Alliance has developed really well across the system in terms of helping to engage a whole range of organisations. And there's good representation now on all the various partnership structures. So this seems to develop at significant pace, but we have at least 20 plus representatives on 14 different partnership structures at the moment. And those people meet regularly to share information across the system about how they're finding that. There were examples of engagement in key developments in areas such as autism and hospital discharge and living well, so examples of where engagement was happening well, how people were contributing to particular strategies. DCHS, we know, are doing some really interesting work on exploring VCSE partnership going forward. There was a procurement and commissioning workshop in January that was sponsored by the Integrated Care Partnership, which was looking at how we could make procurement and commissioning more focused in terms of helping to support a thriving and diverse local VCSE sector. And Adult Social Care have been doing some really good information sessions in advance of their commissioning processes to raise awareness around what's coming up and helping organisations to prepare for those. We've got potential new involvements within the ICB around commissioning, and the development of the Women's Hub is looking at small grants around the VCSE sector. We've had some good discussions around data sharing, which continues to be a real barrier towards partnership working. So there have been continuing discussions around data sharing. And there's been an opening up of a number of system training opportunities to VCSE organisations, and now some support for doing a workforce analysis of the VCSE sector. So some progress over the last 12 months, which has been really positive. At the same time, there were a number of issues that were raised, and these perhaps are where the discussion might be most interesting. Next, already there. So in terms of issues, I've picked out some of the key headlines there. I think one of the things that came through was a sense that there is a lack of a system strategic view on the VCSE sector contribution, how to maximise it. And this comes back to this thing around sometimes it depends on the individuals you're working with and the individuals you're talking to. It's not always an organisation or a system or a structural understanding of the sector. So there's a lack of a system-wide view around that. And there is variable awareness, I think, of the sector and the breadth of it and what it brings. And this year, I think, because of many of the challenges that exist, there just hasn't been enough capacity or space on either side to try and develop that relationship. It's felt often as though everybody's dealing with constant panic and demands and difficulties, and there isn't the space to step outside and explore that. And I think still some of the structures and approaches make engagement difficult. So I talked about the number of partnership structures and representatives. When we think that those representatives ideally need to be engaging with a much wider sector and feeding information in and out, to be able to do that is incredibly challenging in the timescales that are presented. And it's quite difficult then to think about some of the new approaches around co-design and being more proactive to address that. Local place alliances themselves were quite concerned, well, very concerned about the future development and engagement of the VCSE sector, given the current consultation on cutting discretionary VCSE grant funding in the county. There were real worries about what that would mean in terms of the capacity to engage the sector at that level, and also to take best account of some of the intelligence that organisations have at a local level there. There was another one around moving from support to action. So I think there was a bit of a sense that in the last 12 months, there's been a lot of really positive messages and positive discussions, but it doesn't always translate into practical action. And there was a feeling that maybe that's the next step, to move from a lot of those positive messages of support and understanding what the sector can bring to something that actually shows results. And there are areas, I think, particularly around data sharing, around procurement and commissioning, workforce is an area that we need to do more on. And I think this whole issue around how we involve the sector right from the outset in pathway development is an absolutely key one, because it came out really strongly in the review that we need to involve VCSE organisations in the breadth of the sector in pathways from the outset. And I don't feel that's necessarily happening at the moment. So that's an area that we might be able to focus on. There was feedback around investment approaches, which won't be particularly surprising, but a bit of a concern that the way that we approach investment as a system, both through procurement and commissioning, but also in other ways, aren't necessarily developing the strong, local, diverse, thriving sector that we'd like to see. And in actual fact, in some cases, they're taking us in the opposite direction. We know of smaller groups that can't compete or afford to go for contracts. We know of organisations that have got contracts but using their reserves to subsidise them. And we know there's little opportunity to look at alternative approaches to invest through grants. We'd like to do something, I think, around simplifying access to non-medical services. There was a sense in the feedback that there's been a lot of work in the system of bringing services together to look at how both professionals and people within the community can better access those services so that they're more joined up. There was a sense that isn't necessarily working for the VCSE sector at the moment. There are so many services out there in the sector, so many ways of engaging those services, and we could look at making those more joined up, I think, and make it easier for people to access those. There was something about how the sector is such a potential vehicle to help the system with this greater left shift approach that we talk about, this approach around moving towards prevention and doing things downstream. But there was a sense over the last 12 months that the financial pressures have actually led to people retreating into statutory responsibilities and a treatment-based approach, which has actually not helped in terms of looking at the VCSE sector contribution. And I think finally there was real concerns about what's this discussion going to look like in 12 months' time. You know, if we come back in 12 months, are we going to have a very different discussion where we've seen a lot of organisations disappear, a lot of services disappear, and it's very difficult at that point to be able to turn the tap back on. I think you have what you have, so there's a need there, I think, to be able to be proactive about that. So finally, last slide, where next, just picking out some of the things that came back from the review. These reflect on some of the issues that I've already highlighted. So getting the most from the sector needs a strategic system focus. This isn't a VCSE specific issue, it's an issue for the whole system, I think, if we think the sector has a role to play. And we need a space where partners and decision makers across the system can make this progress happen together. And that can include looking at all the sorts of things that we've looked at and I've just talked about. And there's been some initial discussion in some of the partnership structures about whether the ICP might be able to provide that space, because it brings those sorts of partners together, and maybe there's an opportunity for us to be able to have those discussions in that space. Secondly, we just need to progress some of the work that we're already underway with. So some progress around things like data sharing, commissioning, workforce, pathway engagement, but we need to accelerate those and make them work. And there may be some there may be some steps we can put in place that may even help us to review that. So regular reviews, maybe some checks on committee papers to see whether we've effectively involved the sector in work that we're doing. And if necessary, even setting up some sort of mediation processes where things aren't working well or where there are problems might be helpful. There's a sense that we could be better at identifying, learning from and scaling up things that work well. So at local place level, there was a sense that we often pick up things, there are often things happening really well at local level, but they don't necessarily get scaled up and learnt from, and maybe that's another thing that we could do better. There was a sense that we need to make more of the intelligence that VCSE organisations have around the communities of place and interest that they work with, particularly given that local place alliances are working so closely with local VCSE infrastructure. And I think going forward, there's a question about how that links with things like the Joint Strategic Needs Assessment and the ICB Insight work. And then there's something around access, I think, around how we explore simplifying access to VCSE sector services. And how we better capture the impact of what we're doing. So that's a bit of a sense of a bit of a rush through what's been quite an extensive piece of work over the last 3 or 4 months with colleagues. Very happy to take any observations, questions or comments from people. Thank you.
Right, we open it up to the floor. Any observations, comments, questions? Yes, Cathy.
Thank you very much. I think you know, I applaud A, having the MOU, and B, evaluating, and you know, it looks very thorough to me. I think that's really helpful. I think the things I was going to mention are really a build on what you've already drawn out, to be honest, because I think it has drawn out for me anyway, the key points. One, just to observe, there's clearly been very good engagement. 9,000, I can't get my head around 9,000 groups. Some must be quite small, but we spoke, didn't we? I'm not sure you're in touch with 9,000, but there's a lot. But engagement seems to be very positive. And I was therefore looking at, trying to think about what were some of your blockers. You know, you mentioned data, and I'd be really interested to understand where are we up to on that and what's stopping us having a really good data sharing across not just this sector but any other. That was one thing. Second, you touched on it when just now really, the moving to action. And the last year has been really difficult, but I can only see that the next year is going to be equally difficult. And I just wonder if there's some way of honing the energy. And the Place Alliance space feels like a good one, doesn't it? Because a lot of this is quite local. And I just wonder, what would you need in order to make that kind of work more effectively, really? Because I think it is about moving to perhaps doing a smaller number of things. And then just in terms of the overall evaluation, and you may have this and you've just not shared it, but I think the next would bring it to life would be to share some examples of where the engagement with the voluntary sector has really started to make a difference, some sort of case studies, I think would give us a sense of what's actually happened as a consequence of all of this work. So 3 kind of points, thank you.
And just to respond to those, I mean, in terms of the good examples, you're absolutely right. There are quite a few of those, and it would be really good to share those. And Kim might like to talk about DHIP, actually, which has just won an award around VCSE engagement. So there are some really good examples we could share around that. And maybe around the data sharing, Chris might like to come in around that, because I've had some discussion with Chris around where we're up to with data sharing and how we might be able to progress that. I think in terms of engagement, I think you touched on it in the beginning of your feedback. One of the real challenges is just the simple size of the sector. I mean, you're right to say that a sector that size, you can't engage everybody. It's just too huge. But even with some of the networks and infrastructure we've got, we're probably reaching 2,000 to 3,000 organisations. And there then becomes an issue around capacity and time to do that. And I think that's where we struggle to some extent in being able to jointly have the capacity to do that. And it also requires sometimes slightly different approaches to the ones that we take. You know, it requires a bit more time than sometimes the partnership structures allow. It means sometimes we need to take things out to organisations rather than having to bring things into partnership structures. So I think there are ways of doing it, but it's quite challenging to do that, and would certainly be very happy to talk to colleagues about how we might approach that.
Thank you, Chris Weiner. Just to respond to the data sharing issue, first of all, I think it's important to recognise that the data sharing issues that Wynne describes is not confined just to the voluntary sector. This is the issues that they face are issues which are faced across multiple organisations, both statutory and voluntary, within Derby and Derbyshire. And I'd just like to take people back. I can't remember exactly which meeting it was of this board, but it was about 3 or 4 meetings ago. I think Jane Needham and her team presented a paper around the potential of a Section 251 agreement to facilitate data sharing, data analysis, intelligence across the systems. And we're trying to progress that at this point in time. It will take us probably a few months if things go smoothly. It does require national sign-off for a Section 251 agreement, but actually we're trying to progress that to facilitate the data sharing environment, not only for the voluntary sector, but for all organisations across Derby and Derbyshire.
Yeah, and I think, as you say, it isn't just the voluntary sector, it's an overall picture. But yes, David, please.
Arun Chidambaram from Derbyshire Healthcare. I think really great insights about what are the areas of focus, and data sharing will be one, because that challenge is not unique to the sharing with voluntary sector. We have that within NHS Trust, and the more recent data sharing has given us lots of insights about what are the particular areas of challenge, and if we start working on that, I think it'll improve relationships. And there was a mention about the scale of the challenge, how to engage such a huge sector, and probably we need to focus at a place, because that will be more manageable. And some of the things we need to do as a mental health provider, the scale of demand that's in front of us is huge. And without engaging with voluntary sector, without doing prevention, we can't continue to provide a service. So there'll be a lot of interest from all of us to engage and bring together that local intelligence, because because we have lots of data sitting with us, but without that local intelligence that VCSC have, we won't be able to translate that into action. So quite an exciting opportunity. But when we do the one-year kind of review, I think the data sharing will pick up so many things to work on.
Yeah. Kim Harper, Community Action Derby. And I think one of the examples for me would be Derby Health and Equalities Partnership, which has been community action working with public health, Derby City public health teams. Very much, I mean, it's 3 years, I think, we've been working together now. And last week, we actually won the Inclusion and Diversity LGA Award nationally. And it's such a good piece of work because what we have is more than 60 local connectors embedded in local voluntary sector, linked into the Place Alliance, very much working with our public health colleagues and the health system as well. There's been things like hypertension, which I believe is coming back to the next ICP meeting, a report on some of the work that's been happening there. But it's been a really good example of how at a place level, particularly from our perspective, local infrastructure has been able to work with those very granular organisations and people speaking the right language, appropriate interventions and engagement, really. So really sort of extending that reach into communities and making sure there's a dialogue with the system, right place, right time, and helping to understand that as well. So that's been really, really positive and a brilliant example as how if you work together at a local level, that engagement can really add value to the work that the system is doing.
Thank you. Just say very briefly, because I can't really speak, but I can readily see the need for a more strategic engagement with the voluntary sector, and Carol has your communities in your portfolio, don't you, Carol? I think sorry to be a bit parochial, but I think it would be useful, Kim, if I could have a meeting with you to discuss this, obviously from particularly Derby perspective, but we can also touch on the broader things. So if we could arrange a meeting, I think that'd be really handy. Thank you.
Just on my thoughts before I bring anybody else in. I mean, I suppose I've jotted one or two things down. I think that local government know a lot about the community and voluntary sector, but I'm not sure, and I might get shouted down, but do the NHS know a lot about what they do? I'm only thinking, going back, and I know we're going back a few years, but when Chris Clayton came in to sort the CCGs out, one of the things he'd got to look for saving money, and one of the things he looked at was perhaps withdrawing some of the funding, which caused a problem at the time. No criticism of Chris, he's not here to defend himself, but that will happen, because I don't think probably he understood exactly what contribution community and voluntary sector make. So I think that now that is turned round, and you know it's being acknowledged. And when you mentioned about locality, I think during the COVID you really came into your own. And if speaking with my Erewash hat, because I live in Erewash and I was leader, I go to the health locality, and they're the CVS run the health locality, and you know they do a fantastic job. And as you say, when you've got local people there on the ground, they can, you know, really deliver. It is going to be difficult. I mean, you know, we're out now looking at some of the grants that we make, and we've been making for years and years and years. You know, I would hope that we've had lots of conversations with any organisations that may be affected. And even if money was withdrawn, it's not for another year, but it's also looking at, are we working in the best way? Are you delivering what we need? Can we help you? Because I think that just, you know, you are such an important sector. So, yeah, so that's just my sort of take on that. But anybody else like to? Yes, Jonathan, then yeah, come back to me, Sarah.
Thank you for the report, very insightful. I think it's in the supporting information 4.3, you talk about the impact of funding cuts. And local authorities have obviously been a key partner to the voluntary sector in some cases for decades. Councils have, through a combination of cuts that they've been served by central government, and also rising costs and inflation, it's made it difficult for local authorities to sustain those really important relationships, and it's been hard for us as councillors to manage that. Of course, sometimes when things change, it forces us to work in a smarter, more innovative way. But I know there's further cuts potentially on the horizon. The county's looking at £1 million out of voluntary sector grants. I wonder if you could say something about what that would mean for the sustainability of those organisations and the people which they seek to serve.
Yeah, I think that's a really good question. I think it won't be uniform across those organisations. What I would say is potentially it could be catastrophic to some. Not having that conversation and looking at how we could do this differently. And I know that we're looking at equalities impacts assessments, which I think are important, but actually it's more than that. It's about just saying we can afford to do without this 1 million because it's discretionary. And I'm not affected by those grants because I'm Derby based and the grant funding in Derby disappeared in 2015-16 in terms of local authority funding. But actually that could have a massive impact to those very small communities without looking at this in the round. And my concern is that to take such a large cut is actually salami slicing potentially, and you need to have that very direct conversation with those organisations. And also let's take this as an opportunity to look at how we do things differently. As a system, we're redesigning the way we do things, we're working in partnership, we're going to be integrated. Let's actually be integrated. Let's the voluntary sector, the system, local authority and health sit down and have these conversations about how we do it differently and actually about how we genuinely invest in trying to turn that curve, you know, your 80-20, let's invest upstream and change it around. I do think there's a real opportunity to look at a different way of doing it rather than just going down a cut. And having mature conversations, I think, is really important, not being worried about talking about the fact that this is on the table and looking at those alternatives. And I think we sometimes avoid that.
Can I just come back very quickly on that as well? Just in terms of some of the feedback around that situation, I think there was something interesting around, which is bigger than the VCSE sector, but it was around the whole system shift or desired shift towards prevention and away from treatment because of the recognition of just the sheer stresses the system is under at present. And there was some feedback around it doesn't feel that it's logical to be making some of those cuts to organisations that are working on things like befriending and some of that preventative work when that's the direction of travel you want to head in. But it's understandable because of the financial situation. And I think sometimes one of the problems is that I think it was mentioned in the report that the issue about what's a statutory responsibility and what organisations retrench into isn't always around the preventative direction that we want to head in as a system. So that there are some real tensions, I think, there about where we want to head as a system and sometimes what the financial drivers, the direction the financial drivers take us in. In terms of specifics around some of the reductions in funding, I think some of the real worries around that are around the capacity to be able to engage and develop the sector to play its part. So at a system level, we've already seen some significant reductions in VCSE sector capacity to do that. But if that were to be repeated at local level, it would be very, very difficult to manage what we're doing at the moment.
Thanks, Michelle Arrowsmith, the ICB. Really helpful report, I think. Lots of effort and lots of work gone into that, and something we probably need to come back to when I think, and the review part of checking in where we go next on this will be really important. And I can just let you know that from an ICB point of view, we have protected the funding to the VCSE sector this financial year. It has not been without its challenge in doing that and has had scrutiny, but in terms of valuing the pound into that sector, we have been able to do that. We recognise some of the challenges and some of the things that we need to do to support the VCSE sector. I think the place conversation is certainly one of value, and certainly we will continue to work in that space and take that forward. The one that I'd just like to mention is commissioning. I think, and Carol, to your point about do we really understand what the value is and what actually is possible to be delivered by the VCSE sector? I don't think we always do, and I think it's something we can work from a commissioning point of view, because actually if we get in there at the outset, that can make quite a difference. Often we've gone too far down the line before we can actually draw in value from this sector. So it's certainly something that we are looking to work with Wyn and colleagues.
Thank you. Just a couple of points, and actually one follows on from what you've just said about the added value. One of the discussions that was had recently, we were talking about the impact of cuts, was the impact on actually the volunteers who are doing those jobs. For many of them, that is what is keeping them out of, say, mental health services or other health services, because it's improving their well-being. And those are the sorts of things that you can't get back, because once that's gone, it's gone. And that's my second point, is in 2018, there was, people will remember, I'm sure, there were some cuts then, and we actually had a homeless hospital discharge scheme across the whole county, which was largely lost because of cuts to NHS funding. And I think we all know what pressures there are on hospital discharge now, and I think what a shame, what a lost opportunity, because that could have been built on. It wasn't perfect, and I'm sure we could have improved it, and we could have integrated it better into the NHS. But it just seems to me that that's an example of where you can act something which at the time didn't seem to make much difference. But 6 years down the line, we know that there is a difference, and it was a shame to have lost that.
That's the thing as well with prevention as well. It always takes a long while to kick in, doesn't it? Cassie and then Ellie.
Yeah, Cathy McLean, Chair of the ICB, I forgot to say earlier. Just think about this and sort of building on what others have said. It feels to me as though we could now, given all the good work that's gone on, move to a place where we're a little bit more, I think, what's the word, purposeful in a strategic way of saying, so what would good look like? What are we trying to achieve? And how do we link this back to our strategy? Because we've got an integrated care strategy around starting well and living well, etc. How might the voluntary sector link in there? But I would distinguish quite a lot between the strategic stuff we need to do to perhaps focus on outcomes, but the delivery, just reinforce, sounds to me as though the vast majority of that needs to be at quite local level, at place alliances or neighbourhoods or whatever, really quite local. But if you get that right, how does that all add up to start to move the dial on the bigger things for which we're responsible as a collective, really? So that feels to me, I don't know if that sounds right, but it feels as though we really need to kind of move on to that space of being really clear and not suck everything up and think we have to do 9,000 links from a system. We don't. I mean, I think it'd be impossible.
Thank you. Ellie Holston, Director of Public Health for Derbyshire County Council. Firstly, I just wanted to speak out in support of the voluntary sector. I think, they're absolutely key partners, and as you mentioned, Councillor Hart, during COVID, that really came to the fore. The voluntary sector mobilised far quicker than we in statutory services managed to do, and we're on the ground supporting communities right from the outset. And I think we've really moved our conversations on, and I think the Memorandum of Understanding has really helped that. So we're having more of these strategic conversations, and it's really good that this is here today. I think, picking up on Cathy's point, I think there is that difference between the strategic and the operational. We often get caught up in the conversations about contracts and grants and activities, but this is about the VCSE as strategic partners in helping us to achieve our outcomes, and this is the Integrated Care Partnership, which is about how do we integrate, how do we have these conversations as a system, and we're still having, I think, some more separate conversations, NHS, councils, relationships with the sector. I guess the challenge for us is how do we move that into that more strategic conversation and ensure that our voluntary sector colleagues are seen as equal partners in that conversation, because when we're in difficult financial circumstances, as all of the partners probably in this room are, the voluntary sector and innovative ways of delivering services that we can no longer afford to deliver, the voluntary sector are often the solution to that. And so recognising their really important role and recognising that they can't survive without state support, there's very few voluntary sector organisations that successfully survive without some state support. So recognising our role in that and thinking about how we systematise these conversations that we're having and see those voluntary sector partners round the tables when we're making decisions, I think is really important for us to challenge ourselves about.
Is there any more hands? So, Wynne, I hope you felt that was positive feedback. You know, I think it was a good presentation, and I think I'll acknowledge the work that you do. So I think really there are going to be more conversations following on. It sounds very positive. It's how we make sure that, you know, that's carried forward and you are involved more and, you know, right from the beginning. So, yeah, so thank you very much. That was excellent. Right, moving on then, we're going to do the the LGA session follow-up, so I'm not sure, is Kate or Alison, who's are you leading on it? Kate, thank you.
Hello, Kate Brown, Director of Place and Partnerships for the ICB, and I'll kick off and then Alison can contribute. So to remind colleagues, we had a facilitated workshop a while ago where we brought both local health and wellbeing boards and the ICP together, and then there's been some further discussions with LGA colleagues and amongst a few of us involved, and I'd like to acknowledge Hayley Gleeson, who's not here as well today from County, who's been supporting the work that Alison, Hayley and I have been trying to coordinate. So what we wanted today was to just bring a high level. We reported back, I think, a bit of detail last time, but we wanted to move things on. So it's a bit of a sense check and agree some of the key themes that have emerged from that work and that we believe need to be addressed in terms of thinking about how we build and build on the partnership. And we have a further offer from the LGA, and we'd like to get the partnership support to take that offer up and to continue to support us to develop this work. So in terms of that themed output, we asked on the day about the ingredients for successful partnership working, and we also asked about the barriers to that. And so we've tried to draw those together into a set of posed as challenges, which can sound quite negative really, but it's about the areas that we would want to pay attention to be able to support the maturity of the partnership and to move from a similar journey as we heard about with the voluntary sector, moving from that intent and that bringing together to more purposeful delivery and impact. And the things that emerged were around ensuring that cultures and values and the behaviours that we display in terms of those cultures and values really do reflect that system ambition, and have we got the buy-in of all of the organisations to do that? Are we clear on our priorities? We think that they're fairly aligned, and we actually think they are, but Alison will talk about that, but about making sure that right from the top we are working on the same things, and therefore the messaging through all of our organisations and partnerships forums is consistent. And then do we have the structures and processes under our governance to then facilitate really good decision making that system? Because what we hear, and we heard this as we were developing some of the strategy work, that sometimes it's the mechanisms that we use to do decision making and the way we organise ourselves that can make good partnership delivery complex and difficult and can delay things. And also thinking about our resources, are we bringing resources together? Are we thinking collectively about those opportunities? And again, you know, the example of the voluntary sector is one where we perhaps with that shared intent, but we still perhaps think separately in terms of how we move things forward, and how do we collectively in all our opportunities manage our resources for the best benefit of all of our citizens. And then are we doing all of that, links to Kathy's point previously, in a way that then makes a difference, is purposeful, and we can see and track what that impact is. So those things came through from those workshops, and so one of the first things that we thought we'd do, and we could do from the information that we'd got, was to think about some of those priorities and some of those structures and how aligned they may or may not be initially, and at this point. So Alison, if you wanted to talk through that, some of the table of the work that we did on that.
Yeah, thank you, Kate. As you said, I think from that initial session, we kind of pulled out some of the barriers to success, but also some of the ingredients of success. And actually looking through that was reference to things like aligning our strategies and clarity on priorities. So as Kate was alluding to, we've done a desktop piece of work in between times, and the summary of that you'll find in kind of the appendix of the paper. So we just reviewed really kind of the functions, vision of the health and wellbeing boards and the integrated care partnership, but also trying to particularly look at the areas of focus, population outcomes, priorities, etc., think there's probably slight differences in languages, so we perhaps didn't say these are our population outcomes in each of the documents. But in essence, when we start to look at those, you'll see actually there is already a really strong alignment across those groups, and also the strategies which underpin the groups, particularly in terms of that kind of intent to improve health, reduce health inequalities, that focus on prevention and integration. So I think there's a lot of positives in place in terms of that alignment and structures and intent of what we're trying to do. I think perhaps one of the challenges has been is also describing that in a way that has a shared narrative and meaning and understanding of what that means across the system, and how we collectively put together action that is addressing those, which again I think was reflected in kind of Wynn's update. So I guess that is kind of where we've got to. We're starting to, we held ourselves back, didn't we, Kate, in terms of trying to come up with solutions, although I think some of the proposals going forward are probably within the ingredients for success that we did start to unpick from the session. But the ask of the partnership is really actually what we've described, and particularly what Kate described in terms of those key themes to consider, and kind of what we've set out in the appendix. Is really to sense check that, and does that feel right, and are they the areas for us to start to move forward on? We think there are opportunities which we've started to look at in terms of how we consider agendas going forward. We've got the opportunity, I think you'll see later in kind of one of the later reports, we've got terms of reference due to come back to this group. So I think there are opportunities to, I suppose, take stock and think about where we are and where do we want to move forward to as a partnership, and actually what are the areas that we can focus on and consider in terms of moving us forward as effectively as we can.
And I think just to finally finish, I think what we wanted to do then, if there is general agreement that those are the areas of focus, to use the offer from the LGA, which at the moment we know they've got a little bit of capacity until the end of June. We're hoping there might be more beyond that, but we certainly want to take them up, and we've having some sort of officer type conversations with them just next week. But if we can try and secure some resource so that we then turn to those, if those are the areas we want to focus on, how might we do that? Are there different ways we could work? Do we need any substructures or ways of bringing partners together in different ways to then really start to zip this up a bit more and turn things into action, so that we, so as one of the things we feel sometimes and hear from partners on the ground and from a local place perspective is they can see the high level intent, but sometimes within individual organisations or ways of working, it doesn't get down to them in terms of how they're enabled to work. So we could start to focus attention on particular issues and areas, and the voluntary sector might be one of those areas I'd suggest that we could use to test out whether we are working as a partnership and enabling all of our partners and all of our levels of structures to work together effectively. So our ask is that we continue that work and pick that up with and work then to come back with some further recommendations about particular pieces of work we might take forward.
Thank you, Kate. Any comments? Cathy?
Thank you. I think it's really good and really timely, kind of 2 years since the new systems were kind of set up, to have done this, actually. I think it feels really helpful. And I think it's remarkably helpful as well, and probably no coincidence, is it, that the objectives and key areas of focus for the Health and Wellbeing Boards and the Integrated Care Partnership overlap. The words are not precisely the same, but the meaning is largely the same, isn't it? So I think that's really helpful. I think, again, probably like the last discussion, my focus would be on, so what difference are we making through all this effort and energy? And I think that in order to know that, we do need to be looking at outcomes. And I would just throw in the pot that I think having the ability to look at those and progress, and we know that some of the outcomes that you might want to see ultimately are not going to be measurable in the short term, but some of the things, progress outcomes, you can find. I would just challenge us a little bit to think that the data sharing is dependent on a section 251. Certain aspects of it are, but actually having that commitment to sharing data across is not dependent on that, Chris, is it? It's certain things being used, but I think you can make progress with that. And again, I think looking at I know that, you know, at the last ICP, there was a focus on school readiness, for example. So that's a specific thing that could be measured, that could be done. It fits into that category. But I think we owe it to ourselves to be really, really clear what the focus is, particularly as it's going to be a very challenging period as we go into. Personally, I always think you're better to make progress on a small number of things than to kind of move nowhere on lots. And the inequalities, I mean, some of us had a session with NHS England, didn't we, the other, last week, was it last week even? Goodness, it's very recently anyway, in which it was another reminder of the extremes of inequality we have across our system, whether that's in the city or in the county, actually. And it just makes you realise just how important this is. But yeah, so I think a review of the terms of reference, a review of how we're focused would be really helpful. And the LGA support, I think, is, you know, grab their hands off if they've got it available.
Thank you. Christine Durrant from Chesterfield Borough Council. Sorry, also struggling with my voice. I just wanted to say that I welcome the report. I think the challenges that are there are the ones that I would recognise from the session. I think the other thing I'd say is that at a local place perspective, so from Chesterfield's perspective, the things that are within those challenges are the things that we've also been working on for the last few years. And so we have a set of behaviours and values that we expect people to follow. We have priorities and actions for each of our partnership organisations. And so what would be really, I think, helpful is if we can sort of move together on this at a local and a strategic level, so that we're not coming out with a set of strategic things that are different. And I know that all of the other places are similar. We've heard a lot of the Derbyshire Place Partnership from all of the how the places are moving forward, and we are all on a sort of a similar sort of place. So I think learning from that at the strategic level and then playing it back down would be really helpful. Thank you, Chair.
Yeah, I mean, I think we've learnt that lesson about trying to do too much. You know, we're far better concentrating on a small amount and doing it well. Yes, Duncan.
Thanks. Duncan Gooch, Provider GP. I was just wondering in the report how much we were able to focus on that duplication or that risk of duplication. I think it was mentioned as an issue around governance. We've got County Place Partnership, Health and Wellbeing Partnerships, ICPs, who risk duplicating and doing similar work, and it would be really nice to know that we were pulling together really effectively. And I think that perhaps builds on Kathy's point around what we're actually adding, the so what question. It would be really nice to sort of land that with real clarity, I think, across the system.
Yeah, I mean, we've sort of had this conversation earlier this week about, you know, what are we about? And I think, you know, with the 2 or 3 years, we've sort of settled in. Everybody's got different ideas. There isn't a one-size-fits-all. Yeah, and there could be duplication, but, you know, I put my point forward. I seem to pick quite a lot of stuff up at this sort of meeting because other people, it's their day job and they know everything. When we're sort of councillors and we've got other things as well that we're doing, I find it really useful. But is it wasting people's time? Is there a better way we could do this? So I think it does need, you know, re-looking at, and I think that was why, yeah, we'll snap the AG up and have another session. And Councillor Martin.
Thanks. I can't speak, but I do want to say this. I think Kathy's comment about outcomes is correct, and I agree with Kathy. And I think, but it's not clear to me. I mean, in terms of focusing on outcomes, did I just say that? So I think that we need to do that. I think there's a broader perspective about saying, particularly if you're engaging with health prevention, there aren't always measurable outcomes, particularly within a given time frame. However, there are measurable outcomes, and not all outcomes are measurable, are they? Some of them are qualitative. So I guess my point, which I need to get to quickly because my voice is about to give way, is that I think it's an important point that we shouldn't pass over, but in order to attain that focus, I think we need a bit of work. I don't know who's going to do this work. That's my main point. I don't know where the resource sits to do that work, which doesn't mean it couldn't be found, Kathy, or that it's not important. It's just not clear to me where it sits. So I think if we are to focus, to set some outcomes, or to analyse what would be desirable outcomes in the context of what I've just said about outcomes, then I think somebody somewhere, and I don't know where it is, needs to get together, discuss what that might be, analyse it, set out, a report on it, and then we need to have a focus on how that might be resourced. And if people feel that's already happening, then I'm happy to be informed. Thank you.
No, so I think we're all in agreement that we go forward with the LGA session and have session with them, and sort of, I think a lot of the things, I think we need development session rather than probably the formal ICP to see where we're going. So if you're all happy with that, we'll, I think we're already in contact with the LGA, so hopefully we'll get that sorted. So thank you. So if we move on to Effective Blood Inquiry report, that's over to you, Robin. Thank you.
Thank you. And so this is our first meeting since the publication of the Infected Blood Inquiry report. And just as a partnership, just really wanting to acknowledge the publication of that report and to acknowledge the recommendations from it. So I'm just going to read a small amount from the report. So firstly, we'd like to formally recognise this as, in the words of the report, the worst treatment disaster in the history of the NHS. And secondly, we commit to considering the implications of the recommendations within our partnership. And I have listed there not all of the recommendations, some of them relate nationally rather than locally, but the ones that I've pulled out that relate locally around the actions that we need to take. So they relate to how we learn from incidents and how we ensure that learning is incorporated into our practice, how we work together to prevent future harm to patients, and this is partly about safety, it's also about the duty of candour and about culture within organisations. There's some specific recommendations around how we monitor liver damage for those people who are affected, and also how we work to ensure the safety of blood transfusions into the future. There's a particular action around ensuring that we find all of those who are undiagnosed, and there's a belief that there are still people who are affected who have not been found within the community. A recommendation around the safety of haemophilia care, and then I think important to us all around how we give patients and also our population a voice, and how we increase and include the engagement of advocates for patients within organisations. So that's just a summary of the key aspects of the inquiry, and that we also commit to reviewing these as they relate to our organisations and bringing these together as a whole within 12 months to look at how we're responding as a partnership to this. Thank you.
Thank you, Robin. I think we'd all agree about the disaster. It's absolutely horrendous, but yeah, listening to people's stories is awful. Any comments or input on that? Yes, Christine.
Yeah, thank you. And obviously, it's a very serious report that we must take on board. But my question was going to be about how does this work in practice? Is there a subgroup or an officer group that is going to work on this to bring these reports back to the ICP? Just so that we know who we're tasking to do this work. Thank you.
Thank you. So I would ask colleagues from NHS organisations, I believe there's already some work look at this, but I'm very happy to bring this together to bring it back. But obviously, it's within individual organisations that this will be looked at. Don't know whether.
Yeah, that's certainly the case in terms of the individual NHS provider organisations. And I don't know, Chris, whether you know from a clinical point of view, is there an ICB strand from a quality assurance point of view pulling the provider responses together in a similar way that we did with things like LETB at different scale, where there was wider learning across the NHS. So I suspect certainly that's what's happening organisationally, that there will be a strand within the ICB's quality governance work that pulls it all together to feed to you your generous offer to bring it back.
Thank you, Chris Weiner from the ICB. So the first thing I want to say is that I acknowledge this national report, acknowledge the harm which has been done to people right across not only our community but probably every other community in the country. So key to actually working with patients that are already in the system is to know who they are, and that information is held within the individual provider organisations. So key to moving forward with an awful lot of this work is how the individual services within providers engage with their patients. The role of the ICB in respect will be very much around the assurance side of things, making sure that it does get done and that we do have processes in place to engage with individual patients, to identify any patients that have not been identified as of yet, and make sure that we've got high quality services available for those patients. And as being indicated there, I think actually that assurance process will continue through our quality and performance oversight mechanisms within the ICB and within the ICS.
Thank you, Chris. So if there's nothing else, I mean, I think you should go with the recommendations there and review the actions and come back with recommendations as well during the next 12 months. So thank you. So we just programmed a short break here. If we can just have a talk, because we are slightly overrunning, but we start again at 1:45, if that's okay. If you want to grab a cup of tea or a cup of coffee, I think it's still out there.
So there are some slides, a few slides. You've obviously got the paper, and I'll assume that everybody's read that, so I'll not repeat what's in there. So on my slides, which is not up there, and I think maybe it was to do with the colour of the font, we've got the vision that we have worked on in Derbyshire together. So I'll read it out to you. It's in the paper. It's working together to make Derby and Derbyshire smoke-free by 2030. And I think that's the first time that we've shared that vision here with the partnership. It's been worked on by partners across the system. Absolutely don't worry, Lindsay, it's fine, don't worry. So we've worked on that. We've worked on that across the system, and we'd like your endorsement on that today. And when we talk about making Derbyshire smoke-free, we're talking about prevalence of below 5% by 2030. And then we've got 3 aims that sit under that vision, which are to eliminate inequalities in smoking rates and tobacco-related ill health, to tackle the social and economic harms caused by tobacco in our communities, and to reduce the prevalence of smoking and tobacco use. So, I've lost the slides altogether now, sorry. I'll just wait for them to come back up, shall I, because I'm talking to onto the second one. Thanks. Don't worry, well, I'll carry on. I can talk to you. So the first slide is really about the prevalence. So there we go, prevalence of smoking. So in Derby and Derbyshire, there are 122,000 smokers, so still 15.3% of our population, adult population, smoke. And it costs our system a huge amount of money in terms of that additional care and support that people need through the burdens of ill health and through the economic harms caused by smoking. So specifically to the health system, it costs £46 million a year in medical costs and £32.5 million a year in social care costs. And overall, smoking in the ICB area, the costs are over £1 billion. And smoking is one of those things where we've actually got really good evidence about the costs and the consequences of smoking. Other health behaviours, perhaps less so, but smoking, you know, the case is really, really strong. The figure I really wanted to draw your attention to is the 1,354 premature deaths across Derby and Derbyshire each year that are caused or attributable to smoking. And we had a conversation with our Department of Health and Social Care colleagues the other day about this, and I am trying to find something to illustrate that figure in terms of a population or something that brings it to life in people's minds, because that is a huge number of deaths, and if we had that many deaths from any other cause, we would be throwing everything at it. And we've sort of become so used to smoking as being a cause of preventable death that it almost doesn't register with us in the same way as it should. You know, it's still the leading cause of preventable ill health and premature death in Derbyshire, Derby and Derbyshire, and indeed across the country. It's intrinsically linked to health inequalities, so it's the greatest burden of ill health are with our most disadvantaged communities, and it also has that knock-on effect. So there's over 22,000 carers in Derbyshire caring for people who have smoking-related illnesses, and it's responsible alone, smoking is responsible alone for half of the disparity in life expectancy between our most and our least deprived communities. So the burden created by tobacco is still unacceptably high. Move on to the next slide, please. So over time, you know, we have been trying to tackle this for a long time. We've known for over 60 years that smoking leads to lung cancer, but it also leads to a wide range of other health issues as well, and causes of premature death and morbidity. We have seen smoking rates fall slowly over time, but what we have seen in a report that's been published very recently is actually that progress is stalling. And the reason for that is because younger people are taking up smoking again, and that's cancelling out the rate of older people who are starting smoking. So we've seen people restarting in their 40s, but also the uptake amongst younger people. So progress is stalled. We've already tackled a lot of what we might call the low-hanging fruit, or the easier people to support to stop smoking. So we really need a concerted effort around this agenda, both to support those who do smoke, but also to stop people from smoking in the first place. So on to the next slide, please. So there are inequalities in key groups. I'm sure this doesn't come as news to anybody, but it's worth noting that in both Derby and Derbyshire, around 1 in 8 pregnant women smoke. And when we look at both premature births, low birth weight, and sort of deaths in the under ones, smoking is often attributed as a risk factor. So when we think about those deaths, we're not just thinking about older people who've made a lifetime choice to smoke, but we're also thinking about that impact it can have across the life course. It perpetuates existing health inequalities. So you can see in these groups that smoking rates are far higher than the average. So around a quarter of our routine and manual workers across Derby and Derbyshire smoke, and more than a third of our social housing residents smoke. So that, they are key target groups for us in terms of supporting people to quit. Next slide, please. Thank you. So in terms of the national picture, this is just to give you a sense of the kind of reinvigorated conversations about smoking at a national level, and why now is the time really for us to focus on tobacco control. So there is a national target, which is that England will be smoke-free by 2030. At the moment, we are way off achieving that, and it's unlikely to be met until at least 2039. We've set that ambition for ourselves in Derbyshire as well, and that's aligned to that national ambition, but we recognise that it is a huge challenge for us to be able to make real inroads into that. There was a national review called the Cairn Review that looked at the burden of tobacco on health and made a number of recommendations. Some of those we've seen translated into policy over the last couple of years. So we've got 5-year new funding that's been announced for local authority stop smoking services. So that's very specific around doubling the cessation or the stop smoking capacity in our services. That's gone to both local authorities, and it's just about doubled the investment that we put in. The tobacco and vapes bill, we did mention that here last time. That didn't make it through Parliament before the general election was called, but actually it has raised the profile of this issue nationally for us, and we hope to see that or a version of that in the future. Tobacco dependency treatment services is another one I just want to mention. So that's come from the NHS long-term plan, and there's funding from NHS England that comes down to integrated care boards for that, and that is a service to support people who are inpatients in secondary care, in maternity services, and with severe mental illness. And so we have established a service in the county and city. Not all areas have done that, but we have got ours up and running, and it is really kind of building up in, particularly in UHDB, where it was an award-winning service last year. And we've got Swap to Stop, which is just the name of the government scheme, which is about encouraging people to move on to vapes as a quitting aid. And there's some very clear messaging around vaping that, you know, if you don't smoke, don't vape. But if you do smoke, then vapes can be a helpful way to quit smoking. Okay, so next slide, please. So in terms of why would we tackle tobacco control at a local level? If we do that, we're going to improve the health of our individuals, families and communities. We're going to reduce health inequalities. It will help to lift people out of poverty. Smoking is an incredibly expensive thing to do. It will help to build resilience in our health and social care system. So as well as that direct burden of ill health, we know that people who smoke have longer recovery times from elective surgery, and it creates a wider burden that that's not necessarily as visible as some of those things that we've understood for a long time around the burden of smoking. It protects children from harm, and it will help to reduce crime. We'll be aware that there's a lot of work that goes on around tackling illicit tobacco in our communities, and that, you know, that's a really important element of the work that we do. Okay, next slide, please. So where we want to be in Derby and Derbyshire, we kicked off this work with the sprint methodology. So we brought partners together to look at some focused time on how we wanted to really shape this agenda that was led by Jane Needham. So we've got a number of pillars in there that we're focusing on. So stop smoking support, really important to help people to quit. Smoke-free environments, we've still got a long way to go on some of that. There's still public sector organisations that you can walk into across Derby and Derbyshire. We have to go through a kind of fog of smoke as you walk through the doors. You know, moving that out of kind of public view is something that I think is important to denormalise smoking. Prevention is really key, so stopping the start. So we know, I've just said that as smoking rates are declining, there's a stalling of that, and we're seeing more people restarting or young people taking up smoking, and actually we really want to work hard to prevent that. Regulation and enforcement, which is around illicit tobacco, and comms and marketing, so finding new ways to reach those people that perhaps we haven't reached yet. Okay, so in terms of the next slide, please. So another thing we've done is established our governance structures to be able to drive this work across our system. So we've got a new tobacco control strategic board, which links into the local health and wellbeing boards and into the prevention and health inequalities board, which reports into the integrated care partnership. We've got a tactical group which deals with the operational work that we are developing or have already got going on. And then we've got comms and engagement and prevention and key kind of work streams that sit underneath that as well. Next slide, please. So I don't expect you to be able to read that, but just to say that there is an appendix that's got the detail around some of the key actions that we have worked through in the sprint, around some of those things that we want to start to get in place so that we can really ramp up our stop smoking work in the county and city. In terms of the progress we've made, we have completed health needs assessments for Derby and Derbyshire on tobacco control, so we've got a good foundation on which to understand and to build the work. The Stay Well sprint, which I mentioned, which was driven through the Integrated Care Partnership strategy, that focused initially on tobacco control and has really helped to kickstart this work and this approach. We've set up our governance structures. We've agreed here that smoking is a priority for the Integrated Care Partnership, but also in the Integrated Care Board. We have got a tobacco dependency treatment service established. It's doing particularly well in UHDB, and we have secured the NHSE funding for that for a further year. And then we've got the planning that's going on around that funding of the stop smoking services, and the Derbyshire Director of Public Health annual report, which will come out in the next couple of months, is going to be a call to action for the system around this work. So last slide, please. So in terms of action for system partners, these are some of the things that have come out through the sprint, and these are not kind of set in stone, but things to think about. So we do need to consider as a system how we invest in tobacco control as we go forward. What does it mean for it to be a priority for us, or how do we really start to get this work moving at pace? We have, within the funding that's come to the city and county, agreed to support some insight work and engagement work with some of those key groups that I've mentioned in terms of finding new and more effective ways to engage those people who are most at risk. We've got a tobacco control plan with a strategic aim and ambition and measurable targets. So there's something for us to bring back here to be accountable for the delivery on. We have talked about how we get that visible sign up to this. So one of the suggestions there is to have a Derbyshire Tobacco, Derby and Derbyshire Tobacco Control Pledge, and to ask all partners to sign up to that. We also want to adopt a Derby and Derbyshire Integrated Care System consensus on vaping as a harm reduction approach. We have had a vaping consensus statement from the East Midlands, and we have shared that with health and wellbeing boards. The increase in smoke-free places, I won't go through all of that list, but support trading standards is the other bit. So within the government's original plans for tackling smoking, there was some additional resource announced for trading standards, but that is very small compared to the rest of the investment across smoking, and we do need to recognise that illicit tobacco is a key challenge for us, and not to lose sight of that when we're thinking about smoking within this health and care system space. And finally, to support our own staff to quit smoking, or I should mention also, which I missed out, was the very brief advice training. So there's something about upskilling our teams across Derby and Derbyshire to be able to drive footfall to those enhanced stop smoking services as well. So that's another key plank of this. And there's many more things that have been suggested and we're exploring, but that's just to give you a sense of some of the things that we are going to be asking system partners to consider and to think about how we actually embed these as we go forward. So the recommendation in the paper, I think, is just to endorse the proposals and the ambition for the system and to recognise the work that's been done to date. Thank you, Chair.
Thank you, Ellie. Yes, Chris.
Thank you, Chair. Thank you, Ellie. The first thing I want to do is thank Ellie, her team, and everybody else who's been involved in terms of tobacco control, smoking cessation across Derby and Derbyshire. This is an incredibly important area of work, focus of work. And I was really struck reading the report by one sentence, actually, which is in the report. It's in section 3.1. I'll read it out just to make sure everybody is aware of what it says. It says, smoking remains the main cause of preventable ill health and deaths, and is responsible for half the difference in life expectancy between the most and least deprived. Half the difference. And look, I know for many people, after the sort of changes around legislation of smoking in public places, they've felt that the job is done. It's not. There's a lot more work to do in this space, and as Ellie pointed out, actually, some of the numbers are going in the wrong direction. So I think this is an incredibly important area of work, focus work, and I fully support the recommendations of the paper. Thank you, Chair.
Thank you, Chris. Councillor Moore.
Thank you. I can see that's a really excellent report, and lots of really excellent report work has gone into it, and you know, I can't disagree with it, but this body will know that I'm a slightly different voice sometimes on these issues, and no doubt that's because I actually originate from one of those smoking infested council houses. So I think there's an issue about some of this that bothers me a little. It doesn't bother me, but it's actually hopefully a more helpful suggestion, because I think I suppose there's sort of analytical points I'd make about whether I'm not doubting that smoking is harmful, please let me stress that, but when we say with regard to health inequalities that it's, you know, responsible for what the point you just made, sorry, I am a bit fuzzy today, the point you just made, Chris, I'm sure that Robin will tell me, and she could probably no doubt give me the articles in the Lancet or something that have analysed this, but whether we know to what extent it's because somebody is smoking that they retain those, you know, early deaths, or for example, when they've had elective surgery. Is the smoker the fact that is it the fact they smoke, or is it that it defines that means they don't recover as quickly, or is it more, you know, that they actually have all sorts of other issues that are going on that mean they're not going to recover as well? So obviously that's just it's almost a rhetorical question. You don't really have to answer that, but I'm not doubting the evidence. I suppose I'm just aware that it, you know, 60%, over 60% of people who live in social housing don't smoke. And I think there's you know, we do have to be careful here about some social stereotyping and controlling these people, telling them what they're going to do. We don't have this language in relation to many other health behaviours, particularly red wine drinking, alcohol drinking. We have an epidemic of home drinking that's excessive among the middle classes. So I'm just getting this out there because I'm not very well today. And you all know what I think on this anyway. And I'm absolutely pleased that Sunak had to pull that ridiculous suggestion about the, you know, I am going to go on a bit because I'm not very well. You know, this business about the not, so, you know, blocking an age and then having an age, which would never have worked practically. You know, nobody's going to comment on this in room, but it's just as impractical to bring into as the whole, you know, small bolts policy was. It just doesn't, it's not very sociologically based in terms of what human behaviour, and actually a system where hopefully we still have, you know, liberty and rights in this country, you know. So all those things, ranting on a bit. So I have some concerns, Ellie, about the tone sometimes, you know, I really do. But I'm not challenging you on that, please. It's not a personal challenge. It's not, I do think the report's excellent, but so I have doubts about, my question would be, are we sure some of these stats are actually correct? Because when you put them in the terms you did, Chris, it's very alarming, but there are many things going on in people's lives, and not just the smoking. Take away the smoking, other health inequalities will persist, and sometimes it could be the smoking that's keeping those people away from Kingsway, not other things. So that's that. It's about the tone. But I suppose my more constructive point would be that, for example, Move More Derby, they're working with Sport England now. Some of you are probably aware of this, on these new projects around trying to get people to move. So the hard to reach people, so the people who never move, you know. And there are those people, sadly. And like, you know, they've tried everything, and basically there's a number of people where it's just not working. And so they're like, they've got this project where they're going back to the drawing board, and instead of going in, you know, they're talking to those people in the most pain, for many of us who do move quite a lot, you know, it would seem quite painful really, but, you know, we're dealing with those people's realities. This is the idea of the project, so it's at very initial stages. You probably know about it, Ellie, actually, sorry. But the movement, that Sport England project around getting people moving. And I suppose getting to my point is that, you know, have we actually talked to people who smoke? Do we actually all know people who smoke, as I do? And the people who won't stop smoking, do we talk to them about why they smoke? You know, that kind of, that sort of approach. And, you know, I'm just asking if that's part of this in some point. And is that actually also, do you think, helpful? Thank you.
Thank you. And so, yeah, I mean, picking up firstly on the point about stigmatising smokers, I think we want to be really careful that that's not what we do, and that's not what this is about. And actually through this approach, I think there's a bit in there about insight and marketing and comms. We've recognised that engagement is really important with smokers, and to understand perhaps in ways that we haven't done before actually around what are the challenges and how can we support people. So I think this is very much about supporting people and not about stigmatising people. And we recognise there'll be some people who will not want to give up and will never give up. But that prevalence, so when I talked about that ambition about making Derby and Derbyshire smoke-free, that's about having a prevalence that's under 5%. So there's a recognition it isn't about targeting everybody, every smoker, and making people feel targeted, but it is about making sure that we're absolutely in the right places with the right support, that we understand what people need. Because actually there are so many benefits to not smoking in terms of that financial side of things, in terms of the health and well-being outcomes, in terms of, you know, that burden that is on families when they have to watch someone they love going through a smoking-related illness. And you've said there's over 22,000 people in Derbyshire supporting people through really difficult health conditions because of that smoking. So absolutely take your point about that. And in terms of the evidence, smoking is one of the evidence base around smoking is probably the strongest of any of those health kind of, I don't like the phrase health behaviours, but for want of a better phrase, those health behaviours, the evidence is really strong. But absolutely, again, take your point that those risk factors for poor health do cluster in people. So, you know, inactivity, poor diet, alcohol use and smoking. You know, there are people, many people who will have more than one of those. Though it's not about that in isolation. And we have talked about how do we link our work together to support people around all of those things, around becoming more active, around improving diets and all of that. So that's very much recognised, and actually that burden of ill health goes exponentially higher the more of those risk factors that are clustered within individuals. So I take on the points, and we really want to make sure that we do get the tone right when we take this out, both to the wider system, but also particularly to our communities.
Thank you for the report, very insightful. Some of the data is very striking, like Chris said, and it drives inequalities. Having worked in mental health, that's a big issue. And thinking about smoking cessation, it is a wicked issue. Not the smoking, the cessation, the program is a wicked issue. I'm speaking from my scars of trying to implement smoking cessation in an inpatient unit. Didn't go anywhere. So it's truly a wicked issue. Just a suggestion about linking it to more positive kind of message. When we do the comms, it's about access to green spaces, walks, and all the other positive stuff. Because there's a lot around stop smoking, smoking cessation. It gives a deficit space, isn't it? It's just linking it to a positive space. Thank you.
Just on that, the second to last one there, support trading standards. Some of the money from the government is to help trading standards with illicit tobacco. And I wasn't ignoring it if anybody saw me messing with my phone. I was trying to find the email. Trading standards at Derbyshire had a prosecution or raided a shop only a couple of weeks ago, and there were 363,000 cigarettes and 20 kilograms of rolled tobacco, which is equivalent of 18,150 packs of cigarettes and 400 packs of rolled tobacco. And as soon as you get rid of that one, there's another one sets up. And a fortnight before, it was illicit vapes and things. So we've got a losing battle. I mean, vapes are better than smoking. We keep saying that. We don't even want people to vape. But now there's lots of counterfeit coming in. So you're not only sort of battling against the legal ones, you're battling against very illegal and trying to get cheap cigarettes. So anyway, if there's nothing else moving swiftly on, thank you, Ellie. That was, and I know how much work the particular team at DCC do. They really do. And I can remember even when Dean was there doing some pictures, it got me walking inside an inflated inside of a body. It was horrible, but it was trying to get the message across. As you say, with the expectant mothers, how do you get something? It's perhaps horrible, but you've got to get that message across. So, right, so... Number 9, Stay Well update. So it's over to you, Jane. Thank you. Could you put your microphone on, please, Jane?
That's better. There we go. Just let me move it across. Hi, so it's Jane Needham, Director of Strategy, Partnerships and Population Health at DCHS. So I lead on the Population Health Management Steering Group, which is delivering against the Stay Well key area of focus. So it's our detailed report this time with regard to the progress that we've been making. And hopefully everyone will have had the opportunity to read the report. And there were two main areas that we wanted to draw your attention to. The first is around consideration of the future remit of the Population Health Management Steering Group, which has come as a result of the discussions we've been having amongst the partners who attend the Population Health Management Steering Group and then other partners working into the system. So that is focused around how, specifically how the Stay Well key area focus can continue to be driven forward, and also how are we meeting as an ICP system the requirement that an ICP should have a population health management function. And then the second part of the paper is around an agreement on the future focus for the Stay Well agenda, because it follows on beautifully from Ellie's presentation there. We did the smoking cessation sprint and then handed over the work that had been done in the Population Health Management Steering Group into the Tobacco Control Strategic Board that Ellie's talking about. And you can see how that sprint approach into an exit route of an established group has worked really well. So if I just move us to the first point around the Population Health Management Steering Group. So the paper explains the background to the group being established, which was back in in the summer of 22. And it was established it predated the ICP strategy, and it was established on the basis of some one-off funding that came into the system around increasing the skills and capacity of population health management. And there were 4 programmes of work centred around PCNs in general practice, which had 6 months worth of input. And then as the external funding withdrew, what became really clear is that the ability of us as a system to continue to drive forward on those approaches became more limited. It was that external support that had really helped us. And at the same time as that support was withdrawn, the integrated care partnership strategy began to be developed, and we had the 3 key areas of focus, one of which was Stay Well. And so the Population Health Management Group, because it really fitted with the skills and expertise we'd got in that group agreed to take on the Stay Well key area focus, which, as everyone will be aware, is the prevention and early intervention to reduce the incidence of respiratory cancer and circulatory diseases across Derby and Derbyshire. We have delivered what our reflection is, and a question for the board here, is that we have pivoted who attends the group in order to support the smoking cessation work, because obviously it's very relevant to some people and less so to some of the other partners who are attending. We had great representation from the voluntary sector, from all of the providers, from general practice, and in particular from our comms teams in public health, within the 2 local authorities and within the ICB. So there was a really great focus around smoking cessation. What we recognised is that everyone who works on the sprint has their day jobs to get on with and is coming together in order to do that work because it aligns with their values or with work that they are trying to drive forward in their own organisations. But capacity is limited, and it is very clear that people are doing getting on with their day jobs and doing over and above in order to deliver against the sprints. What we're very aware of is that we do from time to time get requests in for broader population health management work, which we don't have the capacity to do, and we don't have access to, as a population health management steering group, to data analytical support in a systematic way. So I suppose it's that highlighting that we could be under an illusion that we have a population health management function in our system, but what we have is a population health management group who are driving forward the Stay Well agenda using a population health management approach. But if we get requests in for the population health management pieces of work, we're not able to fulfil that. So you'll see that the recommendation within the paper is for consideration of the Population Health Management Steering Group to become known as the Stay Well Delivery Group, because that is the work that we are getting on with and doing, and then consideration around what is a broader population health management function for the system that pulls together partners under a SRO function. So that's the first part of the paper. The second part of the paper then moves us on to more practical question for the board around our next key area of focus. So we have completed the smoking cessation, had a period of time of dual running and hopefully being of help to the group that Ellie is leading in doing that really close transition to make sure that everything that we had started was handed over. What we've taken is big learning from the sprint approach, and the key learning is in the paper, but I'd kind of summarise it as the partners sitting around the table in the Population Health Management Steering Group felt that, from a proper evaluation of how it had gone, a sprint approach was really valuable to drive forward relationships and gave people an energy which they didn't have within working in usual processes. It felt positive to move forward things quickly. And it fostered integration and relationships between partners in a way that, if we'd have stuck to a traditional approach, probably wouldn't have achieved it. A key thing is to have an exit route, so there's no point in having a sprint unless you've got an exit route into system level working. Another key learning for us is the pre-sprint phase is as important as the sprint phase. So the pre-sprint phase is very much around identifying who the partners are, identifying the data that is available to you, ensuring and testing that that data is being presented in a way that can be understood by the partners who you wish to engage with, and really importantly looking at what have we got currently in our system, where are we investing money, where is the positive action happening, and how aligned to the current evidence base is that action. So this pre-sprint phase is really important, and actually we didn't give ourselves enough time in the smoking cessation to do that. We underestimated the length of time that would take. So having completed the smoking cessation, we're now, there's a real appetite and a real push from the people in that group to say, right, okay, where can we next put our action, because it's feeling positive to work in an integrated way and we like the sprint approach. So we've had a period of a few months where we have taken views from people as to where we should be focusing our efforts, and you'll see in the report we've had a broad consideration of different areas of focus, and we've consulted with a broad range of partners, not least on the Population Health Management Steering Group that's probably got representation from around and about 10 or 12 parts of the system. There is no one solid consensus, so there's not like we've got anything where 100% of the people voted for one particular item, but the consensus is that obesity for adults is where we should put our efforts. And interestingly, in between prepping this report and attending today, there's also been the report that's been circulated by NHSE Head Department, who came to the meeting that Ellie was referring to, where they do cite within their report that obesity for adults is an area of focus for us. What we are proposing, taking on board that we need to make sure that we do this pre-sprint well, is that we have a pre-sprint phase that is really targeted towards those partners who can help us with developing the data in a way that is meaningful for partners to make use of it, assessing the evidence base, assessing the activities that we've already got on going on in the system, and undertaking that real gap analysis and the insight from our local populations as to what are the acceptable methods of us delivering evidence-based interventions around reducing obesity for our population. Really great conversations with Ian Potter, with Duncan and with Andy have indicated that that would be helpful to PCN colleagues. And in particular, what we want to do is to make sure that we engage with PCN colleagues, and they are front and centre to this. We've taken the paper into the Integrated Place Exec, and the Integrated Place Exec are in agreement that they would be a really excellent landing place for this work once it's developed. So at the point at which we're ready to move from a pre-sprint into a sprint and then take it into an exit route, Integrated Place Exec would be willing to be that exit route in the same way that Tobacco Control Group was for smoking cessation. So I think I've probably said as much as I need to say there. So there's two proposals. The first is consideration of the population health management function for the system, because the current population health management steering group is not fulfilling that in a way it feels is sufficient. And then the second is around a pre-sprint for obesity, with a view to, over a period of time, developing it so that Integrated Place Exec would be the exit route for the sustainment of any interventions we put into place. So I'll close there.
Thank you, Jane. Yes.
Thank you for the report. Really helpful to know what's happening in our system. But there's still a lot more we can do, particularly around the infrastructure, digital infrastructure. We've got lots of functionalities of overlaying data sets, and that can give us really good insights. Obesity is a key theme to work on, but there are lots of other areas that we could be working on, learning from other systems like Frimley and Cheshire and Mercy. They're doing things like case identification. if we do that targeted approach, it will help us solve some of the problems. We'll be really interested in working with this group on that.
Thank you, that would be fantastic. We've started to do some early looks at our radar system to identify, for example, people with elevated blood pressure who are obese, who are smokers, who are not yet on a diabetic register. There's a likelihood of those being at increased risk of pre-diabetes. We're starting to do that very early population health management approach, but let's work smarter, not harder. If we can draw on thinking from places like Frimley, that would be brilliant.
Yeah, thank you for the paper, Jane, and thank you for the presentation afterwards. I took something different from the paper when I read it to what I heard from when you were speaking, so I just want to explore that a bit. So when I read the paper, I thought, right, this is a focus on obesity. This is about ensuring that we know where there's a home to pick up obesity issues going forward. Perfectly comfortable with that. What I think I heard you say, though, in the presentation is actually you want to see a bit of a refocusing of the work of your group and more of a focus group to that work on the Ageing Well agenda as part of the population health management. Did I hear that correct?
No, Chris. So there's two elements to the paper. The first part of the paper is around the population health management steering group, as it is at the moment, is concerned that we could be being perceived as a population health management function for the system. And in reality, what we are doing is driving forward the Stay Well agenda of the Integrated Care Partnership Strategy. So the Stay Well agenda. So it's the conversation of, are people comfortable with that? Because the pace at which we can deliver population health management is going to be curtailed by our capacity to deliver against Stay Well, or we need to put into place we need to consider putting into place a separate population health management function. And then the second part, Chris, is around for that group, who we would propose start being called the Stay Well Delivery Group, is we want to move on to a next area of focus, and that we're recommending that would be obesity.
So thank you for that clarification, Jane. So if I can say that I recognise that population health management is not in the place that we want it to be at this point in time. There's a lot of work to be done in terms of developing the population health management approach across Derby and Derbyshire. But I think it's really important that we recognise that population health management covers the whole of the life course of people living in our communities. That's the Start Well agenda for younger children, the Age Well agenda, and the Live Well, Die Well aspects of life and that life course approach. So, look, I'm very comfortable with that clarification. I think as a partnership, we just need to recognise that actually we've got more work to do to get our population health management approach in the place where we want to, supported by the tools that's required to do that, and with the right resources wrapped around it.
Thank you. So, two questions, two answers, Jane. Apologies for the back of my head. So, the first one was a population health management question, and absolutely, completely acknowledge that you're focused on a population health management approach to Stay Well, and that we do have gaps, and we've had conversations before, generally, haven't we, Chris, around the gaps from an intelligence perspective as well, and our ability to have that approach. So absolutely recognise that is a gap, but also completely support your suggestion that you continue to take a population health management approach to the Stay Well agenda within the group as the first one. From an obesity perspective, I just wanted to add a bit of extra thought around that. So we've got, as a system, we've got a Children and Young People's Healthy Weight strategy, which looks at a whole systems approach and looks at children and the management of children and their healthy weight. So part of that whole systems approach may have an influence on families and on adults, but we don't have another strategic approach that will look at adults. And importantly for adults, we've got other aspects of that pathway which include medication and surgery potentially within that. So there is much more that we need to think about when we're thinking about healthy weight, in addition to what already exists from that Children and Young People's strategy. And I think there's already a lot of work happening and issues being raised by the system around obesity, but there isn't a coordinated response. So I think this is a really good opportunity of not adding in additional work, but pulling together existing work and making sense of it and giving us that direction to it. I think it's really important that during this pre-sprint and through the sprint work that it not only identifies the gaps, but also the leads for the work and the home for it. And I absolutely agree that the IPE is the ultimate landing point for this, because it links really nice with a place approach. But I think it does need a doing group identified that can then report into the IPE. Yeah. So somewhere underneath the IPE that is actually coordinating the activity, because the IPE can oversee it, but there's not the time there to give it that approach. And I know you mentioned the Obesity Alliance. I think that's a forming.
It's forming, yeah. It's very, very early stages, and I've had conversations with the chair and with people who attend. They're very keen to be involved in the sprint and the pre-sprint and the sprint work, but it's very early in terms of that group being established.
Yeah. So I think we've got some similar models, haven't we, around the Sexual Health Alliance that reports into the IPE. So a similar sort of model for that. Yeah, thank you.
We've got Cathy, Duncan, and then Tracy.
Thank you, and thank you for the report, and clearly a lot of work that's been going on, so that's great. I'll deal with the two bits, really, or several bits that you've got in the paper. So the steering group, I'm not 6 weeks in, currently in a position to comment really what should happen to it, but what I would just offer as a reflection is that everything I go to, I hear about more different groups, so it feels as though there's a lot of groups. Now, that might be an illusion because of the fact that I'm just hearing about them, but I just wonder if, if you're thinking about doing something, and clearly I think if you're going to do something around population health, it needs to be all-encompassing. I think you're right in that it needs to be kind of across the piece. But I just wonder whether or not pursuing the LGA work or whatever is to also look at how we're dividing up things. Just a reflection, I could be completely wrong, I accept that, but that just feels like that. And then on population health management, my observations would be the same as Chris. It does need further development. We know of places not far away where it is further developed, and I think that can be very helpful. But it feels to me as though it needs to go back to some of the earlier discussion about the data and the information and how we're using that, because that's the bedrock, really, of how you can do that. So those things feel very linked. And then coming on to obesity, obesity is clearly a massive challenge, and we know we've got the data around that for this patch. I think, though, what I'm hearing, though, is, tobacco, obesity, hypertension, all these different things. And actually, partly to, I think, I heard the end of Alison's point, this may well be a very, very overlapping group of people who have quite a lot of these different things. And I just would challenge us as to whether or not we've got the capacity to do things in sort of individual silos, or whether we should be clustering more around people and saying, actually, we need to help them address all of these things. Because to be honest, the root cause of a lot of this is just a lack of resource. There was another thing out, wasn't there, in the press I saw the last 24 hours or so, the close link between dietary issues and poverty is really stark. So there's almost for me all these things are good, but if we get to the root cause, what can we do differently? So not really very helpful, but just a few reflections on what it's feeling like. Thank you.
Thanks for the report as well. It reads really nicely. I think probably Cathy's point, but perhaps I will articulate it slightly differently, is around, so what we're describing, I think, here is to say we're not going to focus on the delivery of a population health management function. We're going to focus on the staying well and obesity, which makes me feel slightly concerned that this is a really important piece of work that we might not be focusing adequately on. And whilst data is an element to it, and having population health management at a strategic level has value, it's a really, really important function within our system at an operational level, at the level where we are delivering direct care to people as well, to try and make the most out of what we have across our system. So I'm slightly nervous by the risk of losing that focus on the data, the workforce, the change culture, everything that's going to be associated with a population health management function, that we won't deliver as much as we could deliver in our system.
Is it okay for me to respond? Yeah, thanks, Duncan. So you're articulating our worry. So as we sit in the group, which is a group of people who have day jobs and have an interest in, have a values based around prevention and reducing health inequalities, and have roles which touch upon some of the agendas, that we are galvanising and pulling on goodwill and capacity to do that. And we are recognising at the same time that this system should have I'm probably going to be fairly vocal here, this system should have a population health management function, and we are at risk of giving ourselves a comfort blanket that this group is doing that, and it's not. So that's a part of this paper of, are we comfortable with that? And if we are, we will continue to use a population health management approach to drive forward the Stay Well agenda. But if, for example, people are wanting information on other broader issues, we are not currently doing that. And so there's just that decision in the system of, do we need to actually establish, do we need to accept that, and that's what the Stay Well group's doing, or should we be galvanising an effort around a proper population health management function in the way that Kathy's describing? We know other systems have got. So you are absolutely nailing what we're bothered about, Duncan, yeah.
Yeah, thanks. Actually, my comment's probably redundant because the conversation's moved on. So I think, Duncan, Jane was absolutely raising your concern very explicitly, which is, as you've said so brilliantly, Jane, there's a group, and we here at the ICP have said, right, that group, take responsibility for some very specific things around the Stay Well. And we're all saying, yes, take a population health management approach to smoking and then obesity. And I think you're absolutely not saying, and then we won't do, you're saying really explicitly then, how are we going to develop that population health management function more broadly? And that becomes a question. But the group, as set up at the minute, cannot do that. And it's not right to do it either. It's a group. So that's moved on. My second point was just about the place bit. And I think I agree, Robin, the IPE can take a role in kind of supporting and coordinating and overseeing. I think delivery, actually, we've heard throughout the afternoon about the local places, or too many places, where this gets delivered. Duncan, Christine, the groups that are working in Chesterfield, in Erewash, are doing it all, and then an obesity alliance like we've got with sexual health, which is kind of framing that, the best practice, and providing that enabling support. I think that's how we'd envisaged it working. So I just wanted to really support that as the thing, but call out, which I think Jane's trying to do in the paper, where do we go with that broader population health management function? Because a steering group of people who are all just coming in on top of lots of other things isn't going to do it.
Yeah, so sorry, just 2 points from me. So just coming in on the population health management. So I agree. I mean, your recommendation 2.3 says to consider the development of a system level PHM function developed under an SRO. I mean, I think as a partnership, we should say, yes, we support that, and we need, and I don't know whether it's the integrated place executive that needs to go away and answer that question. I don't know who in the system takes that forward, but I think this board should be saying, yes, we absolutely recognise the need for that. The other point was about actually the individuals and the issues that they have around obesity, smoking, the links. Certainly at a Chesterfield level, and it sounds like at Erewash, we're actually having a conversation at the system at our level about how do we properly engage and listen to communities and individuals that are suffering across the whole of the wider determinants that are leading to these issues, and how do we have that conversation with them about how actually we should be changing our services to deliver for them. So I can guarantee you that conversation and how we have that conversation is being discussed at a local level. So if we get a strategic approach to obesity like we've got with smoking, then I think that's great, and that helps us to develop our approach to implementation.
Thanks, Christine, that's really helpful.
So just to re-emphasise, in terms of recommended approach, I fully support developing population health management to deliver all that it should across Derby and Derbyshire, and that's where I want to see a focus of attention. Recognise we haven't got it done today, but let's keep focusing on that. But I then want to just pick up on something which Kathy said, which I thought was exceptionally helpful, actually. So people live in place. They don't live on an obesity pathway or a smoking cessation pathway. They live in a place. And actually, we need to focus on how do we deliver in place, recognising that there are multiple different communities across Derby and Derbyshire, each with their own bespoke issues, each with their own bespoke cultures. And so I think actually a big challenge for us as we go forward as a system is to, yeah, we may do some focused work on smoking cessation, we may do some focused work on obesity, but how do we translate that into a methodology and approach which actually reaches out to those communities and delivers on what they need to see delivered? So I think it was a really helpful intervention from Kathy. Thank you.
My point really is just to try and take this perhaps back to an executive level. I think in terms of, there's some practical things I think need discussing here in terms of SRO. There's also some practical things in terms of population health management and the delivery element around place. And we do have an executive group in terms of the integrated care system exec, and I'm just wondering if there's actually some need to take some of that back to that group to have a discussion. And I think particularly to Kathy's point around and to Alison's point, actually there's a number of things going on with a group of people, and actually if we started to focus in on those groups of population, so it's just a suggestion. I think that there are a number of execs here who could perhaps put some practical movement forward to some of the points you raised in the paper.
Thank you, Chair. So it's just a quick point for me, but it's a bugbear I often have, that we often conflate population health management and population health, and the two things are not necessarily the same. And as a system, we did agree definitions about this some time ago. And I do feel that if we are going to reinvigorate the approach to population health management, which my understanding of that is it's predominantly a data-driven methodology for understanding the health of our population, segmenting it, understanding some of those cohorts of people that might have risk factors clustered together. We need to be clear what we're talking about, and we need to be clear how we locate that within the structure alongside that broader population health focus that brings in all of that wider work. So it may be helpful for us to redefine or to revisit our definitions and make sure that we all have a common understanding about what we want to achieve.
Thank you, and thanks, Ellie. I think to some degree that was the point I was going to make, which is actually if we have that strategic intent, and those communities are really important, but I think we've got lots of scale-upable programmes going on that can then do that detailed work and that operational work. But I think for me, actually having that strategically, this is where we are, and then there's delivery and the what next bit and how we implement it is really, really important. So taking that intelligence and that insight from the PHM and then making that happen on the ground, we can do that through those place alliances and through those really good links that we already have, like Derby Health and Equality Partnership, like the work that's going on in Chesterfield.
Sorry to come back. Just one quick point is I meant to say earlier is, and I'm sure this is happening, you've just reminded me, it probably is happening, I presume locally, is the voice of the people in all of this. So what do they want? So when you say we should go to the communities and so on, to me, it's go to communities and listen to what they want and how they're going to solve their problems, because actually that's my experience is that's where, and it will be really different in tiny little different communities, perhaps streets apart, estates apart, different bits. For me, there's just a strand there that would be good to map in to say the solutions lie with the people who are living the lives, and we can offer some support, or place in particular, I think. I'm always on about place because I do think all this happens very locally. We can only provide some enabling and supporting intention, really, I think.
Yeah, I won't re-articulate my support of local places and local communities in supporting health. Michelle, I think just thanks for taking that on and taking it to the execs. It's fundamental to the delivery of the transformation required in primary care. It's probably the single most important enabler for us to be able to transform and deliver more effective services. So it becomes really important for our future, I think, as well as the now.
Thank you. And also, once again, I'm picking up on Kath's point, which I totally agree with, and as a councillor, I just work like that all the time. And I think, you know, working with people, understanding what they want, understanding why they do things, understanding in the end if that's their choice, is really important to a health system, you know. So I think that's really, really vital. And there's a lot of work that obviously the councils, I would argue, are probably ahead on this all the time, because it's just in our DNA, Carol, isn't it? And it's what we have to do. You can't really be a council or councillors without engaging with all that. So it's really, really important. And I just think one of my, just very quickly, one of my priorities as the cabinet member for health in Derby has been the Child's Healthy Weight strategy, and I'm looking forward to going to the summit tomorrow in Matlock on that. And I think this is an excellent addition to that, as Robin explained. I mean, I have had rather a lot on my plate in the last few days, so you must forgive me. But I didn't know if I was only going to be here this afternoon, so I haven't read all the papers in advance, which I usually do. So I don't know the focus of this, but I know the point about the Child Healthy Weight strategy, which I talked extensively with Andy White, who manages it. It's very clear about, because there are stats around the numbers of obese and also where that's concentrated in terms of economic deprivation, but actually, you know, about 66% of adults are either overweight or obese. And once you get to that in a population, I mean, I'm sure you all know this, but, you know, it's in a way, it's an individual problem. Sturdy, well, you know, determined individuals can avoid this plague. But obviously, there's something else going on massively, isn't it, as a society and a culture. And so what I was going to say was that I haven't read this, so that's unforgivable. But I suppose within the approach, there has to be an honest understanding about the limits of a health system. Obviously, the health system has to address this, but it is about things like the food industry, and the food industry in particular, and food supplies, and the quality of food, and you know about all the research that's been done on this. So it's just, and then the need for a hugely strong national steer on this. So that's all there implicitly or explicitly in the Child's Healthy Weight strategy. So I hope that is also going to be incorporated into this. There's the system can do in Derbyshire, but there are also limitations. Thank you.
Thank you. Just in picking up in terms of the local place role in terms of bringing together both the local insights, of which I think there are closer to those communities, and because it's a wider partnership at that local level, so you've got the representation of the council's voluntary sector, that feels it clearly is where that needs to happen. But I think, and I know we've got representatives from local places here, but not to speak on their behalf, but I think the thing that would be most helpful to drive through any of these pieces of work, whether that's an individual targeted piece around obesity or smoking, or whether it's around a population health approach more broadly, is that that somebody somewhere has done the work on the data and has brought that together and can align that with the evidence and the support so that each local place doesn't have to go and either try and drag that data together because, as Jane said a few times, the people around local places are just there as part of other day jobs too. There's not dedicated resource except very minimally. So as much work as we can do centrally, do once, do effectively, as much as we can then give that information alongside what's best practice, what makes a difference. Then local places can take that and use that, align it with the other things in their area and the knowledge of the local groups, the local people and what's important. I think that, I just wouldn't want us to miss that the fact that that's a really crucial step. So when we talk about local places doing things, they can only do it if there's that step and that support to enable that to happen.
Thank you. There's lots of feedback from that, you know, and some fantastic work gone on. But, you know, there's more work to do. I think the feedback that you've got, everybody's very supportive. It's one or two ideas, so I'm sure there'll be more conversations after the meeting as well and carrying on from that. So thank you, Jane. That was really interesting. Thank you. Moving swiftly on, we now have 2 items for information. First one is, I know there's Alison or Kate leading on it.
Thank you. I'll pick these up, Chair, because we're... I'll try again. No, it's not. Making you feel better, hopefully, Jane. It's not just you. So, yeah, we weren't intending to take you through in detail in this report, but just for the information of the partnership, just giving a brief overview of kind of the last agendas of the 2 health and wellbeing boards, the integrated place executive. You've got attached as appendices summaries of the last 2 of those, and then just a brief update from both Start Well and Age Well, Die Well. So I wasn't going to pick anything out unless any colleagues that are part of those groups wanted to pick out or kind of any points of note. No? Me again. So the final item is just on the ICP forward plan. So we've just got listed there kind of the items that are currently in scope for the next couple of meetings. I did just want to particularly point out that the next meeting is due to take place on the 14th of August, and obviously note that is in the middle of summer holidays. So I would ask colleagues if they could let us know as soon as possible if you're able to attend or not, so we can kind of understand whether we've got relevant attendance to continue with that. So that's just an ask from colleagues. Thank you.
And I think, unless anybody's got anything they want to raise, we're actually going to finish 6 minutes early, so with the break. So thank you very much for your attendance. It's been really interesting. I hope you've found it as interesting as I have. So lots of good feedback. Thank you for your attendance.